keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hello, I'm Leslie Shaw, now Associate Editor for JACC Imaging, and we have an exciting talk for you today. I'm here talking with two distinguished experts about medical imaging radiation. To my left is Vaskin Dilsizian, Associate Editor for JACC Imaging as well as a Professor of Medicine and Radiology at the University of Maryland, and another distinguished guest, Ray Gibbons, Professor of Medicine from the Mayo Clinic. Thanks for sharing your perspectives with us today. Let me start with you, Dr. Gibbons. Medical imaging radiation. This has been a very politicized and very sensitive topic about patient safety. Why do you think it is? It seems to me for many years this has been of concern, especially within the nuclear cardiology community. But why has it become so politicized today?
Well, Leslie, as you said, this is not a new topic. It's really an old topic, one that we've been concerned about for decades. It has come to the fore recently because of the rapid growth in imaging and the recognition that on a population basis, we're doing a lot more imaging and there's a lot more radiation exposure. The Heart Association first recognized that this was going to be an issue 4 or 5 years ago, and we commissioned a writing group to look at the science of radiation exposure and to basically create a report to educate physicians and the public. And Dr. Tom Gerber from Mayo Jacksonville actually chaired that committee, which issued a report several years ago about this topic before all the current hubbub.
It's interesting, and JACC Imaging is going to have a highlighted issue on radiation, which both of you have kindly participated in. Vaskin, let me ask you a question about calculation of radiation in this whole concept of LNT, an effective dose and lifetime cancer risk. Is that an easy calculation? Is it something that everybody can understand? If we put it together, will it be a simple concept for us to transfer?
Good question. The LNT, or linear non-threshold hypothesis, assumes that radiation has risk even at very, very low levels. That hasn't really been proven. It's an assumption. And so based on that, we would like to apply LRA, that is, apply the lowest radiation possible for getting quality images and accurate information in patients, which is what we've been doing for several decades. The discussion comes up whether at very low doses there may be even benefits of radiation, so-called hormesis hypothesis, which whether you accept it or not, I think we have to put in the concept that most diagnostic studies that we perform have radiation exposure of less than 20 millisieverts. And anything that's less than 100 millisieverts, there's been no data to suggest that increases incidence of cancer or other comorbidities. And so to put it in perspective, therefore, the calculation of these millisieverts are based on general populations of age, gender-based, and radiosensitivity of various organs, which may vary from patient to patient. And we use weighting factors to come up with a calculation of a dose. I want to emphasize, these are not measured values. These are calculated values. And based on that, we try to use the lowest dose possible.
And we should mention that age and gender are critical in the calculation. So younger people, the lifetime potential risk, it's estimated, but potential risk is greater. And it's also greater in women, particularly for cardiac imaging, because of the radiosensitivity of the breast and the lung in women.
So let's take a couple scenarios, if you will. Let's take a young woman. I'll use young under 50, if that's okay. A young woman under 50, and she has first on atypical angina, has one episode but perhaps would be considered to be in the inappropriate category for testing. Now, that woman would have a different lifetime risk of cancer. Is that the way I'm understanding this? From an 80-year-old, for example, who's had a prior bypass surgery. So what do both of you think? Can we actually use this age and gender concept as well as integrate this with appropriate testing to get on an idea of risk-benefit ratio, if you will?
Perhaps I could just take the symptomatic versus asymptomatic part of this.
Good point.
And Ray, you could take the other. Most of the time when we apply these studies, are usually in symptomatic patients. And if you look at the average age of symptomatic patients coming to nuclear laboratories, they're usually men over the age of 60. They're not the typical patient that you, Leslie, presented, or the younger female patient comes in with atypical chest pain.
Exactly.
And so if we take it from there, and clearly the data support better outcome and symptomatic improvement in symptomatic patients using diagnostic studies. And of course, the therapeutic aspect of this, there's no question. A patient comes in with acute chest pain, the emergency room is setting the elevation, any radiation exposure there is minimal compared to survival. Even in young patients with congenital heart disease, where percutaneous involved congenital correction of those patients, even at the young age, has survival benefits that outweigh the radiation risk. Your specific question is about selecting a test maybe that doesn't have ionizing radiation in a female subject versus not, and perhaps regular treadmill studies. Or
Vaskin has already mentioned the clear benefit of getting the right diagnosis, getting the right prognosis, trying to improve the patient's outcome. We need to weigh that against the risk of the radiation. We have in our paper a figure that shows the risk of radiation, or theoretical risk of radiation, associated with an annual sestamibi study beginning at age 40 in a woman compared to their actual lifetime natural cancer risk. And it's very small so compared to the lifetime cancer risk. So weighed against in that way, the benefit of the study clearly outweighs the risk. I think the situation is very different in asymptomatic patients, and we try to make that point in the paper, where we have no data at this point that doing something to screen them is going to lead to an improvement in outcomes. In fact, the DIAD study published last year couldn't demonstrate any improvement in outcome by a screening strategy in asymptomatic patients. So then I think the radiation risk outweighs the benefit.
So I think if I could take that, the natural risk of having a cancer, lifetime risk, as you pointed out in your figures, about 20 to 25%. Let me just give a couple of examples. If you're having a CT angiography, 10 millisieverts, that would increase the risk by lifetime risk by 0.05%, right, which would be 25.05%. And if you're having a perfusion study where you would have an increased risk, for example, sestamibi, it would be 0.03, which would be 25.03%. I think that's what we need to highlight, that we're talking about a very small fraction annually to the natural history.
When I went over those numbers with my wife, she said, well, what's all this hubbub?
If we had one take-home message, would it be fair to say the younger person, the 50 or 60-year-old, the latency period for that cancer risk is greater just in terms of life expectancy than the 70 or 80-year-old. So we want to be cautious in the younger individual and have that discussion. So physicians who are listening to this would be encouraged to have a greater understanding, read both of your outstanding papers in JACC Imaging, understanding a little bit more about the risk of radiation so that they can be better informed with having discussions with their patients about risk-benefit ratio.
Absolutely, because I think right now there's a lot of misinformation in the press, and the public is very worried about this, and I see that every day in my patients.
Well, we certainly don't want to have patients who are really sick and can tremendously benefit from the procedure, having a concern about radiation when the benefit far exceeds the risk. Any
That's
final
correct.
Comments, Vaskin?
Oh, no, I think that you're emphasizing that to always remember that as long as the benefit, whether it's the cardiology or even oncology, the radiation dose and finding the disease and treating it would outweigh any potential risk, even not measured or calculated lifetime risk is so small.
And the second message is that we do want to do our images at the lowest radiation dose possible, because there's plenty of data to suggest that there's room for improvement with respect to that issue.
So this has been a truly informative discussion, and I hope that everybody listening to this will read this issue of JACC Imaging, because I think it's going to be very informative and help people to frame the subject of medical imaging radiation and put it in the appropriate perspective. So once again, this is Leslie Shaw for JACC Imaging. Thanks for joining us.